Friends, I welcome you all to yet another session of the Clinical Neurology Forum. And today we have Professor Sundar, Professor of Neurology at Sri Ramachandra Institute of Higher Education and Research, Porur. Sundar has been a student of Madras Institute of Neurology, very astute and knowledgeable clinician. I've been asking him to join for several months now, but he was preoccupied with preparing his daughter for admission, and he has succeeded. His daughter has joined in IIT Madras. I am happy to announce that, and I congratulate him and his daughter for that. And we have Professor Arun Raj team from Trichy. As you know, KAP Vishwanatham Hospital Medical College team is a very good team of postgraduates and faculty. And Professor Arun Raj is heading the team now. And he has been promoted and he's taking up his position as Professor of Neurology at Tanjavur Medical College. With that, I hand over to Professor Sundar, who will be the chairperson, and Professor Arun Raj, who will be the moderator. Sundar, you can take over and continue the proceedings as you would, in whichever way you want. On to Professor Sundar, please.
Thanks, sir. Thanks, sir, for the introduction, sir. Good morning to Professor VN, sir, Professor Arun Raj, sir, and all other participants and my dear colleagues. This is the 44th webinar, I'm told, and this 44th webinar series is continuously managed by sir, and for his age and for his
Sir,
I have to tell you, no, you are told about me, no, so I have to tell about you. No, we all should learn from you. For at this age, you have such a you want knowledge from when we were a student time to till now. So you should learn from you that point, sir. So this 44th webinar series will be moderated by Dr. Arun Raj. Sir is an associate professor of neurology at Trichy Government Medical College and going to promoted as professor.
Promoted already.
Now I hand over.
Only going to join.
Promoted. Okay, sir. Now I hand over to Professor Arun Raj for starting the session.
Yeah, you call Ashwin.
Now I call upon Dr. Ashwin to present his case.
Good morning, everyone. Good morning, sir. Respect, sirs. I'll be sharing the screen, sir. Good morning, sir. The case is as follows, sir. Patient presented with complaints of recurrent episodes of defective vision of one eye followed by the other eye since last 1.5 years, sir. I'll be describing the episodes, each episode as a, sir. Starting from the first episode, patient was apparently normal till 1.5 years back when she developed fogginess of vision of her right eye associated with pain on moving right eye, which was acute onset and worsened over 3 days. The form of difficulty in identifying distant objects followed by near objects associated with difficulty in appreciating colors in her right eye. Examination of right eye at the time of admission, which she was admitted in a private hospital. She didn't came to us. On admission, there the visual acuity was 1/60 on her right eye. Color vision was defective. Field of vision, she had central scotoma, and right pupils RAPD was present. And fundus media was clear. Disc was hyperemic and edematous. Margins were blurred and vessels were obscured at the disc margins. Examination of left eye was normal. Other cranial nerves and spinal motor system were normal. She was admitted for the same in a private hospital, and IV methylprednisolone injections were given for 5 days. Her vision drastically improved in 3 days, and she was discharged from after 10 days. At the time of discharge, her visual acuity was 6/9 on right eye. The color vision got improved. Second episode, patient developed similar complaints of fogginess of vision associated with pain on eye movements and sudden flashes of light in her left eye 1.5 months following the first episode, for which she was admitted again. Here, the examination of left eye at the time of admission showed a visual acuity of 2/60 and a color vision which was defective. Field of vision, she had central scotoma in her left eye, and pupils RAPD was present in her left eye. Fundus, the media was clear, but this showed hyperemia and it was edematous, and margins were blurred with obscuration of the vessels at the disc margins. And examination of right eye was normal. Other cranial nerves and spinal motor system were normal. She was given 5 days of metronidazole injection, and her vision started improving by third day. And by 5 days, she got completely improved. The time of discharge, her visual acuity was 6/12, and her color vision got improved. The third episode, 4 months following the complete recovery from the second episode, she got admitted in a hospital. This is the first time she came to our hospital with similar complaints of difty vision of her right eye associated with pain on eye movements and right-sided unilateral dull-aching type of headache over the right temporal region. During admission, her visual acuity was half by 60. Color vision was defective. Pupils RFPD were present. Since visual acuity was less than 1 by 60, we couldn't do a field of vision. Fundus media was clear. Disc was hyperemic edematous with blurred margins and obscured vessels at the disc and the disc margins. Examination of left eye was normal. Other systems were normal. And we evaluated her. Our routine blood investigations were normal. We have done a CSF analysis. The CSF proteins were normal. 26 and sugars were normal. Cell counts were normal. And the CSF OCBs were negative. Serum VDR was done, it was negative. Serum HI was negative. Serum aquaporin 4 and MOG antibodies were negative. MRI brain with optic nerve cuts with contrast was done, it was normal. Her ANA profile, her P and C were negative. Her VEP showed prolongation of P100 in her right eye. This is the VEP during the third admission in the hospital. We can appreciate the prolongation of the P100 here in the right eye. Her OCT we have done. OCT in the right eye showed there's a disc edema. Disc edema was there. Blood margins were there, and obscured vessels were obscured at the disc margins. And there was a mild hyperemia was present. Even the OCT, there was a edema was present. Even the superior nasal and inferior quadrant, it showed white line, which means that there's a profuse significant disc edema was there for the patient, except for the temporal quarter. She was given IV methylpred injections for 5 days and started her on oral prednisolone azathioprine. At the time of discharge, her visual acuity was 6/12 in the right eye, and her color vision improved. After 10 days, she developed severe allergic reaction to one of the medications, azathioprine, the form of reddish spots throughout the body associated with edema. So immediately, the opening drug was stopped, and she was told to continue with the prednisolone tablet. She was under regular follow-up, and the medication was tapered and stopped over a period of 6 months as she was planning for pregnancy. Then the fourth episode developed after 2 months after stopping prednisolone tablet, and she developed similar episode of difty vision in her left eye. Examination of left eye at the time of admission showed a visual acuity of 2/60 with a defective color vision and pupils showing RFPD on the left eye with fundus with clear media and hyperemic disc and blurred margins and obscured vessels at the disc margins. Examination of right eye was normal. Other cranial nerves, spinal motor system, and Heimann functions were normal. This is a picture of the left eye during the fourth admission. We can see the disc is hyperemic with blurred margins. Not there. And this is the right eye, which is except for mild temporal pallor, right eye is absolutely fine. And the routine blood investigations and repeat CSF analysis were again done. OCBs were again negative. Repeat serum MOG and aquaporin 4 were negative. And repeat MRI with optic nerve cuts with contrast was normal. VEP prolongation this time not in the left eye. P100 was prolonged in the left eye. This is the VEP. This time right eye VEP came to be normal, whereas we can see prolongation of P100 in the left eye. And her contrast MRI brain with optic nerve cuts, contrast, everything was normal. There was no contrast enhancement of the optic nerve was not noted. And even we have done a screening of the spine, cervical spine and whole spine also. Here also we couldn't find any lesions or any contrast enhancement. They were normal. And their optic nerve thickness was 4 mm and left optic nerve thickness were 4.5 mm. And she was started on methylpred pulse therapy and was discharged with oral prednisolone. Her visual acuity improved to 6/12 in 3 weeks' time. And the current episode, that's the fifth episode, she stopped steroids as she was pregnant. 2 months following withdrawal of steroids, she developed defective vision in her right eye associated with pain on eye movements in the form of blackened spots in the center of her vision, followed by slow expansion of the spots, and she had difficulty in identifying colors. By 3 days, she couldn't perceive the things at the center of her vision. She couldn't identify faces in front of her with history of flashes of light on eye movements associated with redness and watering from the right eye. Within a week time, patient developed similar complaints in her left eye associated with photophobia of both eyes. There is no history of objects appearing smaller or bigger in size. No history of any distortion of shapes of objects she has complained. No history of any difficulty in seeing surrounding objects. No history of any floaters or any halos she has complained. No history of any visual obscurations which is worsening on coughing, straining. No history of any feeling of curtain falling over the eyes. No other history is a history of any recurrent vomiting, severe headache, which is precipitated by Valsalva or postural change. No history of worsening of vision or looking to either side. No history suggestive of any other cranial nerve involvement, terminal functions, motor, sensory, cerebellar, autonomic, or systemic involvement. Past history, personal history, and family history were not significant. Summary: here we have a patient, 26-year-old female, presented with recurrent episodes of painful defective vision alternating between both eyes, with last episode presenting with redness and watering, photophobia, and painful defective vision of both eyes. It's in a sequential involvement within 1 week time, without other cranial nerves, motor, sensory, autonomic, cerebellar, higher mental functions, and other systemic involvement. Is a timeline of events. First episode, right eye painful defective vision. Second episode, she had left eye painful defective vision. Third episode, she had again right eye painful defective vision. Fourth episode, again left eye. And the fifth episode, she had bilateral painful defective vision with redness, chemosis, and photophobia.
Yeah, Abhishek.
Ashwin, sir. Ashwin, sir.
Ashwin. Okay. Ashwin, can we discuss from the first slide? Go to the first slide.
Yes, sir.
It's the first episode. No, where do you want to localize?
First episode, she had developed a painful defective vision of her right eye, sir. And she had pain during movement of the eyeballs as well. So I would like to localize this to the optic nerve, sir, because it's a unilateral painful defective vision, which is acute onset, associated with no other findings of any watering, redness, or other chemosis.
So you want to localize in right optic nerve?
No, sir. Right optic nerve, sir.
Why can't it be in ocular media?
Because it can be, sir, her fundus examination that was like normal, sir. Media was clear, sir, actually. When ocular media is there, then some haziness should be there, sir. But it was absolutely fine apart from the hyperemia of the disc.
Okay. Second, painful on moving the eye. What does it say?
Painful on moving the eye, we'll get in actually whenever there's a stretching of the optic nerve, the painful illness can happen. Retrobulbar neuritis can happen.
No, what does it say about pathology?
The retrobulbar neuritis can have mainly painful restriction of eye movement.
Optic neuritis cannot cause it painful, optic neuritis. Anterior visual pathway cannot cause, only retrobulbar will cause.
And it can also cause, sir, painful of the right, painful region of the right temporal region. Pain can happen, sir. Diffuse
pain on moving right an eye tells that it is inflammation is the pathology.
Inflammation is pathology.
So optic neuritis, all other pathology won't have. Hereditary cannot cause painful, no? So the pain says about pathology. And defective vision, right eye with near object and absence of color makes it an optic nerve. It is not optic media. Okay. So the first episode, the pathology is inflammation. And the localization is right optic nerve. Correct?
Yes, sir.
Go to the next episode.
Wait a minute. Wait a minute. How do you explain the fundus picture?
Fundus picture, fundus picture, disc hyperemia was noted, sir. Disc edema was noted, and blurred margin. So this is a suggestive of an acute disc edema, sir, which can happen even in optic neuritis. And disc margins are obscured. The vessels were obscured at the disc margin, sir.
So what do you call it?
Disc edema, sir.
Yes, what do you call that?
Papillitis.
Is it papilledema?
Papillitis.
Okay. So you should know to differentiate between papilledema and papillitis.
Yes.
When you would call it as papillitis, when you would call it as papilledema.
Papilledema is because of the raised. Yeah, papilledema the term is used when there is a bilateral disc edema due to raised ICT, sir. Basically, the raised ICT is causing the edema, that is papilledema, sir. Whereas papillitis, other infectious etiology will lead to papillitis, sir. Or per se, we say disc edema.
Why is this not papilledema?
This is unilateral, sir.
And
no other features, no other features of raised ICT were not there, sir.
Vision.
That
central
is the most crucial point.
Central is more suggestive of optic nerve in optic neuritis, sir.
Ashwin, main point is vision loss plus optic disc edema is equal to papillitis.
Papillitis.
Oh, vision maximum, vision normal and also it has RAPD, no?
RAPD, vision loss, RAPD, and a central scotoma. These things are suggestive of optic neuritis, sir.
Ashwin, in papilledema, you won't get such a gross visual loss. That is the differentiating point, as Sundar was saying, between
sir.
papillitis and papilledema. Profound
Yes.
visual loss is indicative of a neuritis, and if it's not profound associated with edematous disc, it becomes papilledema.
Yes, sir.
Okay, continue.
Yes, sir. Ashwin,
Second,
this is
Yes.
Justin, Dr. Justin.
Yes, sir.
Professor
Yeah.
Justin, Professor of
Yes, sir.
Neurology at Madurai Medical College.
Yes, sir. Sir, Ashwin, regarding this painful on movement, the eye movement produces a painful optic neuritis. If there is a movement of the eye that produces a pain, means it is the intraorbital portion of that too a specific of intraorbital portion of the optic nerve.
Optic nerves.
That will produces the on movement of the eye, it will produces a pain.
Yes, sir. Yes, sir.
Did
Particular
you get the point,
female looking
Ashwin?
illness.
Ashwin, did you get the point?
Yes, sir.
It's an inflammatory involvement of the optic nerve, but that involvement has to be within the orbit.
Yes.
That's what
Yes, sir.
Justin was
Yes. Yes, sir. Yes, sir. Thank you, sir.
saying. No, I should thank you for the point. Thank you. Sundar, if you want second episode getting
see, the point is painful movement on eye movements tells it is pathology, but the pathology is in the not in the retrobal portion, in the anterior visual path. That's what the other intraorbital portion, because then only the eye movement can stretch that optic nerve.
Yes, sir.
Okay, so the first episode localization is in the
Optic nerve, sir. Because of
right
the
optic,
decreased visual acuity as well as color vision is decreased.
and the pathology is
Inflammatory, likely to be inflammatory.
okay. Then improvement with steroids, complete improvement with steroids. What does it say?
Again, it is a inflammatory pathology, sir. There's a good improvement in steroids. Response to steroids suggests an inflammatory pathology, sir.
So does it say about disease itself now? Complete improvement of the vision with the steroids.
It could be like disease etiology. We can consider a demyelinating etiology, which can cause a complete improvement in the vision, sir.
Among the demyelinating, since we'll finish this first episode, among the demyelinating MS, NMO, and MOG, which will have complete improvement?
MS can have complete improvement, sir. MS can have, sir. MOG has NMO has got bad improvement, like comparatively less improvement, sir. Some defective vision will be there, but MS can have a good improvement, sir.
MOG, it told less improvement. What it told?
NMO can have less improvement, sir.
Okay.
NMO
Okay.
can have residual, some can be there.
So both MS and MOG can have
MS and
good
MOG can
improvement.
have good improvement, sir.
Okay. Go to second episode.
Second episode, again, she developed similar complaints of fogginess of vision, sir, in the here left eye. Here, patient also had sudden flashes of light in her left eye, sir. For which she
What
was
does it
again
say? What is sudden flash of light?
sudden flashes of light can we can attribute to retinal pathology, sir.
No,
Flashes of light.
what is it called? Sudden flash of light?
It's called photopsia, sir. Photopsia.
Photopsia. Okay.
Photopsia.
What does it say? Anything? Any significance?
Photopsia per se says retinal pathology, but if photopsia happens during eye movements, even optic nerve pathologists can cause photopsia during eye movements, sir.
Okay. Next slide. Same type of picture. Second episode also.
Good, same type of picture, sir.
Okay, so it's in left. It's opposite side, huh?
Opposite side, sir. Opposite side.
When do you say recurrence, Ashwin? When do you say recurrence of optic neuritis? Can it be the same, or it is you want to say it different? When you say recurrent optic neuritis, is there any definition?
Sir, she got complete resolution from the first episode, and she has got a new episode in the left eye, sir. Her vision was completely improved after the first episode. After then, within a gap of 2 months, she got the second episode, sir. So likely it would be a recurrence.
Recurrence by definition we must at least 4 weeks.
4 weeks.
4 weeks.
Okay.
This happened after 2 months, no?
2 months, sir.
Okay, this is an opposite side. Opposite. This is an opposite side.
Opposite
Okay.
side.
So this is an opposite side optic nerve with inflammation, with inflammatory condition, and it's improving, so it's considered demyelination. Okay.
Yes, sir.
Good. Third also, fourth also same, no?
Third also again on the right eye she got, sir. After 4 months, she got it in the right eye, sir. Again.
Okay, that what is it? Unilateral dull headache or temporal. What does it say? Painful eye movements we have discussed, sir.
That can also happen in optic neuritis, sir. A dull aching pain over the right temporal ipsilateral side can happen in the optic neuritis also, sir.
Or any
Even
other
optic
pathology? Any other pathology you can think of?
any other conditions like if like vasculitic, we can giant cell arteries like vasculitic also we can consider, but her age is a 26-year-old, sir. So GC unlikely, but any other vasculitis can also have the similar picture, sir.
Okay, next slide. Same, no same. It is same. Then this was the first time you were admitted, la?
She was admitted to our hospital for the first time on the third episode. This time, sir.
So there is no albinocytic dissociation. MR is absolutely normal. MS there is no white matter lesion. Serum MOG aquaporin is negative. NMO did not send, right? NMO? Oh, the aquaporin, okay.
Aquaporin for sensor.
Is OCB? OCB?
Sir?
OCB?
OCB negative, sir.
Negative. IG index? IgG index test.
IG was normal, sir. Not report had IG also normal, sir.
Okay, all vascular profile are negative.
All vascular profile were negative, sir.
You also did CSF MOG and NMO?
We did on serum MOG and serum aquaporin for, sir.
Okay, which is better, serum or CSF in NMO?
Serum is better, sir.
Okay, which type you did? Immunofluorescence, cell based?
Cell based, sir.
Okay, sir. Okay, go to next slide.
On a P
okay, next.
And OCT had edema, sir.
In OCT, what will you see in OCT?
OCT, we can do OCT of the disc and OCT of the macula, sir. OCT of the disc we can see for retinal nerve fiber layer thinning, sir. Peripapillary retinal nerve fiber thinning, and in OCT disc, macula we can see for the ganglion cell thickness, sir. So here, depending on the colors, we can appreciate, sir. Green color means it's absolutely normal, and as thinning progresses, it will go to yellow and red, sir. It's very much thin means it can have a red color. If moderately thinning means yellow color will be there. Here it's showing white color, which means it's above green. That means there's a thickness of the disc as such, sir.
This is on the affected side, affected side.
Affected side, sir. Right eye, sir. Affected side.
That is shows edema, so it has to be thicker. But opposite side, previous there had been optic nerve pathology, no? So at that side, any thinning was there?
No, sir. It was normal. It was normal, sir.
Okay. So,
no thinning.
Next.
And we had put her on azathioprine and prednisolone oral medication, sir. And her vision also improved, sir, up to 6/12. And she developed a reaction to azathioprine, sir. Then we were forced to stop the drug, and we continued her with the prednisolone, sir, tablet. And over a period of 6 months, it was tapered and stopped, sir.
Okay. Next slide.
The fourth episode, sir.
No, what does it say about this line? 2 months after stopping steroids, she again developed. Does any disease comes into mind on stop steroid dependency? Pure optic neuritis coming recurrently on stopping steroids, again it recurs.
Say chronic recurrent cryons, sir. Chronic recurrent optic neuritis.
Chronic
relapsing optic neuritis, sir.
Okay, because that's one of the criteria to tell crayon. Stopping of steroids produces the onset of next episode. Okay, so again he had the same the area is same, no? Optic nerve and demyelination, both are same.
Yes.
RAPD is present, you told, no? RAPD means can bilateral involvement cause RAPD?
If the bilateral asymmetricity is there, then can cause RAPD, sir. If symmetricity is there, RAPD will not be there.
Okay, next slide.
Your left eye again showing hyperemic disc, sir, with the mild with the blurring of margins are there.
Ashwin, one point more here. Among the three, MS, NMO, and MOG, In which condition optic disc edema is very significant?
Mog,
Optic
sir.
disc edema.
In
Huh?
Mog, sir. Mog.
Okay. Next slide.
This is the right eye showing absolutely normal, sir. And routine blood investigations and again we repeated, sir, CSF. Again OCB was repeated, sir. Again we did serum Mog and aquaporin, sir. It all came negative, sir. Again we did an MRI brain with contrast, sir. Those all again normal, sir. VP
Where do you send for this Mog and NMO? Where do you send?
Newburgh labs. Here.
Oh.
Newburgh labs.
Sri Chitra used to send us. Sri Chitra used to send us. Sri Chitra.
No, sir.
No. Sure, okay. Continue.
Okay, sir. And this time we can see VP is prolonged in the left side, but right side VP became normal, sir. VP has become normal. And pictures of the other MRI pictures were absolutely normal, sir. Spine screening was absolutely normal, sir.
Ashwin, the VEP became normal in what duration? 2 months or how long?
2 months duration, sir.
It became normal.
VEP became normal, sir.
Oh, great.
Actually, 2 months duration after stopping the drug, sir. She was 6 months gap was there, sir. 2 months after stopping the drug, she got developed that 6 months time. She was not having illness, sir. So in 6 months period, 6 months period, sir.
Okay.
Next.
Next, the fourth episode.
MRI report. Previous slide.
There was no enhancement. Even optic nerve thickness was normal, sir.
Oh, in NMO, how will be the, if at all NMO, what will the findings in MRI?
NMO, there will be posterior segment involvement will be there, sir.
Very
There's
good.
a long extensive of neuritis with the upper chiasma.
In MS,
anterior segment involvement will be there, sir.
Mog?
In Mog, longitudinal extensive of neuritis, sir. But not, it won't reach upper chiasma.
Okay. Next.
What about MRI in crayon?
MRI in crayon.
Crayon, we can get enhancement, sir. We will get enhancement can happen if there's an acute phase. If you do an MRI, optic nerve enhancement can be noted, sir. Up to 1 to 2 weeks, we'll get enhancement, sir.
Did you do a contrast MRI?
Contrast has been done. Yes, contrast has been.
Pardon?
Yes, sir. Contrast has done, sir.
Okay, right.
Contrast was done.
Next. Crayon also, see, crayon la pathology wise, what is the pathology crayon la?
Any inflammatory disease like IgG4 disease or.
So it is 50% is not 50% probably Mog or such Mari. So you can have this long segment like Mog. Okay.
So I stands for inflammatory as well as idiopathic. Most often idiopathic also.
Okay. Okay, this episode?
Sir, eye is inflammatory only, sir, not idiopathic.
Inflammatory, sir.
Chitramalam, yes, sir.
It can be in sonar, sir. It can be.
No, Chitramalam, sir. I agree. By definition, it is only inflammatory.
Yes, sir.
I added idiopathic also for the eye.
Okay.
But it's inflammatory now. Chronic relapsing inflammatory optic neuropathy. Nana idiopathic add panniten.
Because antibody is not known. Chitramalam, sir?
Yes, sir. Yes, sir, Sundar. Sir, at this point, the differential diagnosis is over, sir, or anything else is considered, sir?
We will continue, sir. Finish panna, sir. Finish panna, sir.
Okay.
So,
you continue.
Okay, so the current episode, which is the 5th episode, sir, she had stopped steroids as she was pregnant, and 2 months following the withdrawal of steroids, she again developed, sir, the defective vision of her right eye with similar complaints. This time also, she had complaints of a darkened spot, which happened to be at the center, and slowly expanded, sir, over the field. She couldn't identify the faces in front of her, and she even had a history of photopsia, sir, on moving the eyeballs. She had photopsia and associated features of redness, the chemosis, redness, congestion, and water from the eyeballs noted, sir, this time.
So what is the difference this time? Where do you want to localize all this?
This time I would like to localize with optic nerve and uveitis as such, sir. She had features of uveitis also. So neuritis plus uveitis, sir.
How do you tell uveitis? I am telling it
Because
is congestion due to venous congestion.
her examination wise, like her media was hazy, sir.
Okay.
And the media was easy, and otherwise, chemosis and congestion can happen in uveitis as with photophobia.
So
They are more.
examination finding was uveitis. Examination finding.
Yes, sir. When
Okay.
photophobia was also there, so more likely to be a
So now
uveitis.
we want to change pathology. This uveitis. Which
Now,
condition uveitis is more common? Along with
inflammatory
optic.
condition.
Ah,
In inflammatory conditions, uveitis is more common, sir.
which
No,
inflammatory
among the
condition?
inflammatory conditions.
Ah.
Yeah, which one?
Among the sarcoidosis, sir. Sarcoidosis can have, SLE can have, and the rheumatoid arthritis can have. All of the inflammatory conditions can have, sir. Sarcoidosis, SLE.
Why not Vishay?
Chitrambalam, not audible. Sorry.
Sir,
Sir,
inflammatory
Vishay is another important.
Beshe.
Yes, sir.
Behçet's
BH.
disease can have, sir. Behçet's disease can have, and other inflammatory like sarcoidosis, IgG4 disease, they all can have.
Now it has come from crayon to vasculitic pathology because of this uveitis finding. Vasculitis could be as any of you, sarcoidosis, SLE, Behçet's, or PAN, or granulomatous angiitis.
Granulomatous, Wegener's granulomatosis or for microscopic polyangiitis.
But for that, do you have any history of any kidney, lung, skin?
No other systemic manifestations are not there, sir. There is no history of any recurrent cough or any other lung or any kidney or other.
URI, LRI.
No history of URI, LRI. No history of any constitution symptoms. No history of any weight loss or oral ulcers, dry mouth, dry mouth, dry eyes, oral ulcers.
Okay.
No other constitution.
Any infective to be considered like syphilis, HIV, anything?
Infection, syphilis and TB can be considered, sir.
Yes.
But syphilis and tuberculosis can be considered. But tuberculosis per se won't cause optic neuritis as such. You can have mainly uveitis picture associated with the uveitis. They can have optic neuritis, sir.
Sir, without any major treatment, improving 4 times.
That is unlikely, sir.
Steroids.
Unlikely in case of a infective etiology, sir. But among syphilis can happen at any time of the first primary syphilis, secondary, tertiary. Anytime they can develop any of the manifestations like uveitis or neuritis. Anything can happen, sir. But no history of any other involvement in syphilis, sir. No any rashes or any chancre. Nothing. No other history is not there, sir. No promiscuous behavior. Nothing is there, sir.
Okay, next.
No history of any micropsia, sir. No history of, and no history of any metamorphosis, sir. Distortion of objects are not there.
Metamorphosia tells what?
Mainly macular involvement, sir.
Very good, sir.
And no history of difficulty in floaters are there. No difficulty in peripheral vision. No halos there. No visual obscurations are there. And no other ICT raised ICT features are not there, sir. Even worsening, no other tumor like a compressive
feeling of curtain falling over eyes.
Sir, actually any amaurosis figure, sir. Simply I've asked history of any amaurosis figure, transient loss, anything is there.
Moving curtain like feeling. Visual loss, moving curtain like feeling comes in which condition? Moving curtain, Mari. The curtain move or Mari, visual loss also will move.
Retinal touch.
Very good. Okay.
And now instead of worsening of vision, also the compressive, any tumor compressing of nerve can have similar defective vision. All flashes of light can also happen in the same. But it can happen only during worsening. Vision can worsen during looking to other sides, sir. It is also not there, sir. No history is there. No other history has to have involvement of other cranial nerves, higher mental functions, motor, sensory, cerebellar, autonomic, or systemic involvement, sir. Other past and personal family history were not significant, sir. Summary. Here we have a 26-year-old female presented with recurrent episodes of painful defective vision, alternating between both eyes, with last episode presenting with retinous watering photophobia and painful defective vision of both eyes, without other cranial nerves and motor, sensory, autonomic, cerebellum, and mental functions and other systemic involvements. So I would like to localize
structure involved is optic.
Yes, sir.
Okay.
I would like to localize the first episode as an right optic nerve, second episode as a left optic nerve, in view of painful defective vision with the impairment of color vision and flashes of light. These are the three histories of optic neuritis. All 4 episodes of neuritis. 5th episode in view of chemosis and photophobia and redness and all. I like to localize to a UV8, sir.
So where is the where is the lesion? What is the lesion is? We have discussed now. So finally, what do you want to put?
Etiology wise, considering all episodes, I would like to consider an inflammatory pathology as the first differential diagnosis, sir. It could be inflammatory, it could be sarcoidosis. In young female, it could be a SLE also. It could be Behçet's, it could be rheumatoid arthritis. But features suggestive of in sarcoidosis, other systemic features are not there, sir. Even the biochemical parameters we had sent for, everything came negative, sir. All vascularity profiles were negative. But this clinical picture of optic neuritis, recurrent optic neuritis with uveitis can happen mainly in inflammatory etiology, sir. Can happen in inflammatory etiology only. So that will be the first differential diagnosis, sir. Second, I would like to say
disease. Inflammation is pathology. What is the disease you want to put first? We have discussed no. So what is the disease you want to put first?
Sarcoidosis. I would like to consider, sir. Then
just
SLE.
because she had uveitis.
SLE.
You're praising sarcoid because she had uveitis.
Yes, sir. Final episode she had uveitis. So I would like to consider it as I would like to put inflammation as the first differential, sir. Inflammatory etiologies, mainly sarcoidosis and SLE, sir. And followed by Behçet's and other like IgG4 disease. But
any autoimmune can present like this, autoimmune encephalitis antibody.
Autoimmune CRMP5 can have like CRMP5 can have like this, sir. But they can have meningoencephalus. Other symptoms should be there, sir. Autoimmune.
Okay, paraneoplastic. To finish stuff, not likely, but paraneoplastic.
Paraneoplastic also can develop, sir. Paraneoplastic, but there is no history of any tumor as such, sir. There is any GFAP can have GFAP astropathy can have, sir.
Okay. So among all the things, see if without this last episode of uveitis, it is CRION. With uveitis, it goes for some vasculitic cause for or inflammatory autoimmune inflammatory cause for this recurrent optic neuritis. Okay.
Yes, next differential, sir. Next, like inflammatory followed by either primary demyelinating. Uveitis.
We discussed the next slide.
This is the examination findings, sir, of the last time examination findings. Chemos, redness was there, and here pupils. Here the visual acuity is 1/6. After 5 weeks, it improved to 6/24, sir. In bilateral both eyes, 6/24 after 5 weeks. Like last week we have done, sir. Field of vision, central scrotum was in the right eye, sir. Color vision was defective and improved in 1 month period of time. Pupils were 3.5 irregular with posterior synechiae was there. Festoon pupil were there, and in left eye RAPD was there, sir. And fundus media in the right eye and left eye both media were AC, sir. Media was AC. Suggestive of an uveitis. Either it could be vitreitis or it could be posterior uveitis as such, sir. And margins full of blood. Other findings were there. So this is a picture of her eye. We can see a posterior synechiae and the festooning of the pupil was there, sir. Non-reactive festoon pupil with posterior synechiae is seen here, sir. And this is a right eye showing diffuse disc edema, sir. Diffuse disc edema. And vessels are obscured at the margins, sir. And there can be mild pale, retinized pale and edematous, more suggestive of a uveitic picture, sir. In your posterior uveitis, you can get this kind of picture of a retina.
So synechiae is due to posterior synechiae is due to
iridocyclitis, sir. This is iridocyclitis.
Okay.
Recurrent uveitis. And even left eye showed similar picture of a profuse disc edema with the obstruction of margins, and they also had pale retina, sir. So suggestive of a vitreitis plus uveitis picture, sir, on both eyes. Other cranials and admin functions, motor, cerebellar, autonomic, and were normal, sir. So here he have patient who has with recurrent episodes of optic neuritis, alternating in each eye, followed by last episode of bilateral neuritis with features of bilateral uveitis, sir.
Evaluation sarcoidosis is done, sarcoidosis is done. Sarcoidosis.
Sarcoidosis evaluation done, sir. CT chest and AC levels were done, sir. They both were normal, and the CT chest was also normal, sir.
Okay, carry on.
And investigations P100 was not obtained in the right eye. Left eye also there's a prolongation of P100 noted, sir. And perimetry showed enlarged blind spot, sir. In both eyes, there was an enlarged blind spot, sir. The perimetry. And slit lab,
left eye vision was only hand movements, you told.
Yes, sir.
Here you put
How
only
many
enlarged.
fingers was there? Clinically, how many fingers was there? But even one eye central scrotum was there, but perimetry showed an enlargement of blind spot only, sir.
How can it be? Because okay. Okay.
But sarcoid is ACE and chest CT enough.
AC level, serum AC levels were normal, so it was 13 value, and CT chest was also normal, sir.
Now, is it enough for sarcoid? The investigations or anything more may be done?
What
She
could
didn't
be
have,
done, sir, is asking. What else
sir,
could be done?
if she had any lymph nodes, we can go for lymph node biopsy, sir. Any other lung involvement, sir, we can go for other tests, sir. But she didn't have any other systemic manifestations, no lymph nodes were there. So only we could do is a serum AC levels, which was normal, and screening for a CT chest for any nodes. We did, sir, any other interstitial lung disease or not. We couldn't find anything, sir, as such.
Any liver involvement like elevated AST, ALT?
All routine blood investigations were normal, sir.
Any hoarse voice or anything?
No hoarse voice, sir. No hoarse voice was there. No
Dryness
recurrent.
of the mouth?
No,
Anything?
no, sir. No, it is not there. No sinusitis, no recurrent.
Can we go? Can you go for any other investigations to look for more evidence for sarcoid? Like FDG PET or the whole body FDG PET?
Whole body FDG PET, we didn't do so.
Okay.
So PET could be done. That's what SARS.
PET could be, yes, sir. Yes, sir.
Okay. Next.
That is, if you are chasing sarcoid.
Yes, sir.
Because no other detail is there. Chitralan sir wants to chase sarcoid, sir.
Actually, B51 was done.
It was not done, sir. Patient was not
Sundar, does uveitis just have only sarcoid as the differential diagnosis?
No, sir.
Can't it occur in
not-
other autoimmune disorders?
Yes,
Can't it occur even in multiple sclerosis?
Yes, it could occur. But more common in the group of recurrent optic neuritis, uveitis, now you have to think first of sarcoid, but you have to rule out all other things if sarcoid is not there.
In the given context, I think you would consider demyelinating still as the first. I mean, 4 to 5 episodes of good recovery with steroid responsive. Only thing is, one of the episodes which was also associated with uveitis.
The response to steroid is much more dramatic even in sarcoid than even in
Chitrambalam,
yes,
agreed, sir.
Yes, sir.
What I am saying is, apart from chasing sarcoid, it could
Yes, sir,
still be a demyelinating illness. It could still be, I mean, you could chase MS also. Of course, imaging has been absolutely normal. That's so,
Yes,
it's not, I mean, it's not indicative. But what I'm saying,
Yes, sir.
that's also an equally good differential diagnosis.
Yes, sir. Yes, sir.
Okay, continue.
And OCT, we got there is subretinal fluid collections were noted with macular edema. This is the retina, and this is the neurosensory retina, and this is the pigment epithelium. Between the neurosensory retina and pigment epithelium, we can see a collection of fluids. Subretinal fluid collections were noted in the OCT. And here also, we can see there is a so inferior temporal, there's a thinning of nerve not in the inferior quadrant, sir. And there is subretinal fluid collections were seen here also. You can see pockets of collections here. Pockets of collection we can appreciate here. And the B scan was done for the patient, sir. And the B scan of the patient showed exudative serous retinal detachment, sir. Exudative RD was, we can see the retina and there's a gap in between. We can see the retina thin layer and the underlying tissue, there is a collection of fluid, sir. That's a RD, sir. Exudative RD. Serous exudative RD was seen, sir, in the eye.
RD means retinal detachment, is it?
Retinal detachment, sir. Yes, sir. In this picture, we can see there's a here we can see, sir, RD. Here we can see layer of retina, and beneath the tissue we can see a detachment of the retina. This is an optic nerve, sir. As such, retina is attached to the optic nerve here, but detached from the other parts, sir. So there's a collection of serous fluid over there. Is RD, sir. Serous RD was noted, sir. The B scan. Serous exudative RD.
Central serous retinopathy, how it will be? CSR?
Macular edema, sir, actually. Central serous there will be RD will not be there, sir. There will be fluid collection in the
Previous,
macula.
you told macular edema, no, then OCT.
Macular edema was there, sir, but there won't be serous collection, won't be there, sir. Central serous, there will be collection of the fluid is not there. Only edema, macula was edema because thickness of the macula, volume of the macula is increased, sir. That is macular edema as such. If there's a collection of the fluid, that's called in central serous retinopathy, they can have collection of the fluid, sir. Here we are having a retina, and B scan is mainly used for diagnosing RD, sir, retinal detachment, sir. Here we can see a retina and collection of it between retina and the underlying choroid, sir. So there's RD, clear cut retinal detachment.
Like, can't we see RD in OCT? I'm asking. I'm not sure.
No, sir. In RD we won't be getting OCT. We can of the retinal layers we can see, sir. RD per se we can't diagnose in OCT, sir.
RD can be seen in OCT. OCT can pick up RD, sir.
Then go to the previous view. See, large. It look like big.
It depends on which part of the eye is seen on OCT. Suppose we are focusing on ONH. If the RD is near the ONH, then the OCT will pick up RD. If the RD is somewhere else, it will not pick up. It depends on which part the RD is and where the OCT is being focused.
Okay, that is macula.
Priya?
Yes, sir.
ONH means optic nerve head.
Yes, sir. Yes, sir. Optic nerve.
Okay.
Your OCT and this B scan is correlating. I have doubt. I'm asking.
The
B scan is done for the optic nerve, right? You've done the B scan for the optic nerve.
Optic nerve, sir. Yes, ma'am. Yes,
then why are you talking about the macula in B scan?
Macula, I didn't talk, ma'am. I was saying about the detachment of the, B scan, we could see the retinal detachment, ma'am, here. Oh. Retinal detachment can be seen. Macula, I didn't, on OCT only I would talk, ma'am.
Can you show the OCT picture of macula again?
This is a macula picture is only we have OCT of the disc only is there.
No.
The OCT of the disc.
This is macular OCT only. What you're showing now is
this one is a macular OCT.
The macula.
This is
and macular OCT is showing edema and retinal detachment. So the retinal detachment is near the macula.
Okay.
We have done the OCT of macula. This is the OCT of macula. This is the last episode where the patient had uveitis. In this particular episode, there was macular edema. And along with macular edema, the patient had retinal detachment near the macula. That is correct. What you've told is correct.
Sir. Ashwin?
Yes, sir.
Can it be Eales disease?
It could be, sir, but
optic neuritis, response to steroid, macular edema, and exudates, RD.
It could be, sir.
Eales what's the pathology? Ashwin.
Eales disease.
Because it is involved both bilateral, young, inflammatory, it's veno-occlusive, basically veno-occlusive, and it's involved the serous coat, it will produce a vasculitis, venous vasculitis.
Yes, sir, it's a periphlebitis type of.
Yeah.
Venous vasculitis.
Recurrent, as you said, is recurrent visual loss, response once to the steroid, sarcoid negative, all inflammatory, your markers are negative.
They can have.
Okay, go ahead.
They can have vitreous hemorrhage also, sir. Vitreous hemorrhage.
Yes, sir.
Is Eales, is it optic nerve involvement or is it retinopathy?
Retino as well as the optic nerve, sir. Recurrent optic nerve also involved, sir.
Inflammatory optic nerve.
Inflammatory optic neuritis. Venous, sir. Venous inflammatory optic neuritis, sir.
In Eales disease, you will have vitreous hemorrhage.
Vitreous hemorrhage will be there, sir. In Eales disease.
The media here it is normal. There is no vitreous hemorrhage at all.
Common in men also.
And usually, Yields will be bilateral, sir. Can it happen
It's less
bilateral
likely to be.
pericarditis?
Yeah.
Bilateral
It
involvement
used to
with
be bilateral, common in males,
hallmark.
young male,
Young male 15 to
not
20
in
years.
females.
Females. Young male. Vitreous hemorrhage per se is not there, sir, here in this case.
Okay, go ahead.
Harada.
So,
Ashwin,
yes, sir.
Again, which is the dominant feature here? Optic neuritis or retinopathy, or it's a combination of both? Which is more dominant?
Combination of both, sir, with uveitis picture dominating, sir.
Sir, first 4 was pure optic nerve, sir. First 4 episode.
First 4 pure optic neuritis. Fifth episode, we have neuritis plus uveitis with the uveitis dominating features of more prominent uveitis, sir.
Correct, but 4 episodes were only optic nerve involvement.
Nerve involvement. Yes.
So total picture is indicative of a retinopathy or optic neuropathy with retinal involvement.
There's a picture of a retinite uveitis, sir. Uveitis plus optic neuritis, sir, basically. Total picture.
That is the 5th episode.
Last episode, sir. First episode, there most mainly.
First 4 seems to be without any uveal involvement.
Yes, sir, of neuritis picture.
Was walk Koinagi Harada considered at any point?
Yes, sir, we were considering that only, sir. After ruling out all other things, we were considering as VK syndrome. VK syndrome was considered, ma'am. Finally, we concluded that as
Proceed, Ashwin. We can.
Okay. And FAF fundus autofluorescence showed hyperfluorescent spots were there, ma'am. And completion seek we had sent interferon also. We had sent IGRA also. Interferon gamma release assay. It came as positive, suggestive of a latent tuberculosis, not an. We couldn't say whether it's an acute active TB. It is a IGRA per se suggests it's a latent TB. There is an exposure to the organism as such, so it was strongly positive. So differentials finally after all these investigations, the differentials we were considering were first, as I said earlier, we were considering inflammatory etiologies. Among that, we considered Wickett syndrome as the first one. Was inflammatory. What Kanaki-Hirata syndrome as the first diagnosis because of the pan-uveitis picture with neuritis and serous exudative detachment with hyperfluorescent spots in the FAF and subretinal fluid collections were there. And points against were recurrent episodes of optic neuritis alone without uveitis. Were points against one and no other extraocular manifestations. VKH can have extraocular manifestations of dermatological manifestations of poliosis, vitiligo can be there. And neurological manifestations of meningismus can be there, and other headache meningismus, and other features of sensory neural hearing loss, like auditory manifestations are not there. And other differences were SLE. Points 4 were uveitis in a young female. Points against were uveitis which is less severe, and ANA profile were negative. No other skin rashes or other systemic manifestations were there. Third one we considered were sarcoidosis, which points 4 were uveitis with neuritis recurrent episodes. No other systemic signs, no facial swelling, CT thorax and AC levels were normal. Points against suggesting points against sarcoidosis. Fourth one we considered Behçet's disease and uveitis with neuritis points favoring. Against no oral ulcers, no other systemic signs were there. And we couldn't do HLA B27, ma'am. The patient was not affordable, so we couldn't do that. Sir, and Jogans. Also we considered, but there are no parotid swelling, no dry eyes, ANA profile was absolutely normal, ma'am. IgG4 disease also a final inflammatory diagnosis we considered. Uveitis was there, but no other orbital inflammation, no other extramuscular involvement were not there. Orbital involvement was not there. And then we considered infective ones. TB we considered because there's a pan-uveitis picture and IGRA positivity likely to be a latent TB. We don't know whether it is an active TB or not because there were no other systemic TB was not there. So we could investigate further for an active tuberculosis like any lymph node web something. We couldn't do anything. And points against where TB is very unlikely to produce optic neuritis per se. Isolate optic neuritis in TB is very unlikely. They can have uveitis. With uveitis, there will be involvement of choroid and dura, and from the dura and choroid, they can get optic neuritis. So it will start with uveitis. From there, it can spread further, worsen, and spread from the dura or choroid to the optic nerve system. That's the point again. Syphilis, uveitis can have, syphilis can have uveitis picture at any point of presentation, primary, secondary, tertiary syphilis. But other systemic features of syphilis were not there. No pernicious activity, history-wise, no other syphilitic features were not there. And then finally, we would be the last put down the list. We were putting primary demyelinating diseases because the recurrent episodes of first 4 episodes of recurrent neuritis, ma'am. But uveitis is unlikely. But in MS, the literature says MS can have uveitis picture also. Can get recurrent MS can have uveitis picture also. But repeated CSF analysis, OCPs were negative, and we were all among equivalent for antibodies were 2 times done, all were negative. So we considered to be unlikely, and we put the diagnosis down the list. So final diagnosis is we consider as a probable VKH syndrome. VKH can be complete, incomplete, or probable as per the criteria. So we consider it as a probable Ward-Koyanagi-Harada syndrome. And she was treated with methylprednisolone pulse therapy and was started on topical oral steroids. In view of IGRA positivity means it's a latent TB. We have to start her on only 2 drugs, isoniazid and rifampicin. These are the 2 drugs we should give for a latent TB. But we don't know whether it's an active tuberculosis because we couldn't investigate further. So if it's a so we put her on ATD, ma'am. If there's a latent TB protocol, if there is an acute TB per se is there, it can further cause a drug resistance. So we couldn't rule out an active tuberculosis. So with the diagnosis of IGRA positivity, we give her ATD also, ma'am. So 1 month after the treatment, this is her picture, fundus picture. It's mildly resolving, but still there is an edema. There is a disc edema still persisting in the right eye as well as the left eye. And her OCT, her VEP became normal. 1 month after that, her VEP, both right and left eye, her P100 values were normal. So there was no prolongation. It became normal. And even the OCT picture was showing the disc edema. There was still edema part was there. It's showing white. Still there is edema part was there. And her macula edema subsided. Macula edema subsided. There was no edema noted. Our collections, everything subsided. Subretinal collections were all gone. Subretinal fluid collections were all subsided. And when the repeat B scan showing no RD. RD has completely resolved. The exudative RD has been completely resolved. Subretinal fluids collection was resolved. We can see there is no RD as such thing. Optic nerve is nicely appreciated.
How many days later?
5 weeks later, sir. 1 month, 5 weeks later, sir.
1 month later.
With steroids and immunosuppressants, or with steroids alone?
With steroids, sir. With steroids and actually immunosuppressant ATT and steroids, sir. She was pregnant, so we shouldn't give her. We could give her start on immunosuppressants. We gave her ATT and steroids. With that, she got improvement in 5 weeks, sir. All exudates part only there was disc edema was persisting. Vision improved 6/24 bilaterally. Color vision got improved. And examination wise, VEP shows complete improvement, and there is no retinal detachment as such. It got improved. Fluid collections were improved, sir. Only disc edema, mild disc edema was persistent, sir.
You plan to put her on immunosuppressants?
Actually, in VKH, we are diagnosing as a probable VKH syndrome, sir. So probable VKH role of immunosuppressants, if there is a no response to steroids, actually we can give her topical steroids, and if topical steroids in low doses until the whole symptoms resolve, we can give topical steroids, sir. Can be weeks to months, sir. If there are systemic features of optic neuritis, invariably we have to go for systemic steroids. That way, prolonged period of time we have to give, sir. And immunosuppressants are also indicated. Tacrolimus, mycophenol, mofetil, and azathioprine are also indicated in steroid-resistant cases. And in the other monoclonal antibodies like infliximab, rituximab are also indicated in case of steroid-resistant cases. First, we'll go for topical steroids. Then we'll go for intraocular injections. Intraocular steroids we'll give. Then after intraocular steroids, we can go for systemic steroids. Then not responding means we can go for considered immunomodulators and other monoclonal antibodies.
She is on systemic steroids now, no?
No, sir, VKH cannot be a primary diagnosis in this patient. We are not ruling out anything else. So treating it as VKH, I don't think it's...
see, correct. See, Ashwin.
Absolutely. How many times you ask ophthalmologist, how many times VKH presents as a recurrent optic neuritis? It's predominantly uveitis. So,
VKH oda pathology. Where is the pathology in VKH?
yes.
Where is the pathology?
See, the elements inflammation on the melanocyte, sir.
Melanocyte, retinal epithelium on uvea alada. It is not to do with optic disc head or optic nerve.
Yes, sir.
So you cannot change pathology in between. Or where is the lesion in between? You're all along where is the lesion was optic nerve.
No,
Yes.
sir.
I still feel.
I can also tell that with steroids, he had some infection the last time. He had a lot of steroids, infection, some infection causing uveitis. You can simply finish it off. Just because last uveitis came doesn't change your pathology from optic nerve to uvea. The VKH is a primary uveal disease, not an optic nerve disease. Adhe mari Eels disease is a primary retinal vasculitis, periphlebitis.
Periphlebitis, yes.
Periphlebitis. See, you cannot change in between the site of the lesion. Site of the lesion, what is the lesion? If you are very correct about site of lesion, you won't change your diagnosis in between. Just because uveitis came, you cannot change the pathology from an optic nerve to uvea. This case is a primary uveal disease, no?
Yes, sir. But in
my point of view is the patient had all along crayon, CRION, or probably developing MSO, NMO, MAGO. In between, because of steroids, he had this last time some infection. Some infection causing probably some antibiotic TB, something causing uveitis, and you are treated both and it's improving. That's what I think.
Yes, sir.
Again, what I want to tell is, if you all this unlikely for sarcoid, unlikely for Behçet, all these things are not going to change the diagnosis. See, we have had a presentation of cases where sarcoid has been only to one nerve. It can be fifth nerve. Sarcoid can present only a fifth nerve. Sarcoid can present only with second nerve. So systemic symptoms are not necessary. Probably if you wait for 1 or 2 years, you will have sarcoid involvement of many other organs. And just because one uveitis jumping from optic neuritis to a uveitis diagnosis, I don't think this case has to be treated as VKH. So again, still we keep in mind the differential diagnosis of crayon, like most importantly, again, sarcoid. Again and again, we have seen these cases prove to be sarcoid at the end. And most importantly, even without, see, you do not have a clinical evidence of a node, and chest involvement with node involvement only you can see in a CT and in a ACE. If you don't have a lung involvement, ACE is a very poor indicator of neurosarcoid. Even patients with the central nervous system sarcoid, you don't have AC at all. So unless you do a biopsy. So this case, I think optic nerve biopsy will definitely settle the issue if she has another episode of optic neuritis. Or if you want to do that, you have to extensively try to rule out sarcoid. Again and again, you do a FDG PET. See, we have had cases where patient is present only with optic neuritis for 1 year, and FDG PET has shown a granulomatous hepatitis, and liver biopsy has shown a sarcoid. And we have seen patients with a laryngeal sarcoid. Patient comes just with a hoarseness of voice. There's a nodule, you biopsy the nodule, sarcoid is picked up there. So still, again and again, whatever is the clinical discussion with you and Dr. Sundar, Professor VN sir, it was wonderful. But finally, what are you going to treat the case as? Don't settle down with the diagnosis of VKH. It is going to be again and again sarcoid. And many times you have seen optic neuritis in Behçet also. Behçet optic neuritis, uveitis. Behçet is another disease where you don't have a diagnostic criteria. See, we have had patients of after cells of negative Behçet presenting with optic neuritis. And these patients again come with a CVT. So, and they've never had oral ulcers at all. So, and HLA B51 is also not a very definite diagnosis. So again, you have to keep in mind all the systemic disorders. So I still feel this case is going to prove one day that it's a vasculitis. I mean, it's a sarcoidosis, and you will have to you try to do a FDG PET at the center where it's going to be cheapest, and again keep looking for systemic sarcoid. See, one of our patients presented only with a dry mouth later, and we came to understand that it was a sarcoid infiltrating the parotid glands and other salivary glands. So you have to keep looking at the systemic involvement. Sarcoid will one day show it up by involving some other organ where you can biopsy. But still, I feel this case is primarily a sarcoidosis, and if at all you want to treat as one particular optic neuritis, you can treat it as optic neuritis due to sarcoid, not VKH. Don't jump to a diagnosis of VKH. It's an ophthalmic diagnosis where uveitis is predominant, right? Thank you.
Yes.
Yeah, Priya, what have you to say?
VKHN is commonly underdiagnosed, sir, especially by us, because the posterior scleritis will present only with optic disc edema. So we will assume that it is papillitis, or sometimes even when it's bilateral, we will assume that it's papilledema, especially if the patient has features of meningitis or other CNS infection like features. And I have seen one case who had presented with bilateral vision loss with disc edema. When I had specifically referred the patient for to a retinal ophthalmologist to look out for VKHN, he had picked up the areas of retinal detachment. And then it turned out to be VKHN. We could manage it with steroids and later on taper off the steroids. So in this case, the problem is the first few episodes were documented optic neuritis, and after that, it turned out to be something like Koenagi-Harada.
No, retinal detachment, exudative retinal detachment can occur with sarcoid also, Dr. Priya.
It can occur with anything. It can occur with anything. But the picture of macular edema, retinal detachment, uveitis, recurrent vision loss responding to steroids, does happen with VKHN also. Like how it happens with sarcoid.
Your voice is becoming feeble, Priya. Priya, you are
Sir.
not audible.
Sir, am I
better
audible,
now.
sir?
Yeah, now better.
Yes.
It can happen with VKHN. It can be sarcoid. I'm not denying the fact that it is definitely not sarcoid. It can happen. But VKHN also is possible. It is not that this is not VKHN. See, in the first few episodes, there could have been an element of retinal involvement which could have been missed, or there could have been an involvement of involvement of other areas of the eye which could have been missed, which could have been overlooked, which commonly happens. So it could still be VKHN. The only thing,
Yes.
what happened to the OCT every time when the patient was recovering, what happened to the OCT in between? In between, what did the OCT show? See, when the patient had disc edema, the OCT was showing disc edema. The retinal nerve fiber layer was thickened. But what was happening in between?
Ma'am, only one picture of OCT we had taken after 1 month. It still showed edema, ma'am.
But 1 month is not adequate, no? In between means say 3 or 4 months after the episode of vision loss. What happens to the OCT? Does it become normal, or is it showing a little nerve fiber layer thinning? If it is showing nerve fiber layer thinning, then it indicates that the pathology is in the optic nerve. So that could have been a clue for us. Maybe we can do a OCT now. If the patient is not, after the edema resolves, we can do a OCT and see what is happening to the nerve fiber layer, whether it is thinning out. Thinning out means that there is involvement of the optic nerve.
Priya,
Yes,
Priya.
yes, sir. Yes, sir.
Sundar has a strong point.
Yes, sir.
Four episodes, the pathology was in the optic nerve. Fifth episode, it was also in the uvea. What Sundar says is, due to steroid treatment, she could have had an infection, which could have been the reason for the uveal involvement. So
Yes,
he
sir.
shifts the pathology entirely to optic nerve.
Yes, sir.
And in that case, VKH can be, is a differential only with the fifth episode. But of course, you did point out that it could have been uveal involvement, might have been subtle and missed out. But the stronger point which Sundar makes is, it was all optic nerve, and only the last one was uveal involvement, which might be due to an associated infection due to steroids.
Yes, sir. I'm not refuting the point that the first episodes were optic neuritis, unless we had some other evidence for some other involvement, like if there was a retinal involvement or uveal involvement, we can be sure. But this presentation is not uncommon, sir. Presenting as posterior scleritis and disc edema and vision loss, we do see such cases. And then it turns out to be VKHN. Though in this particular case, in the first few episodes, there was no involvement of retina or macula. That is unusual.
Good morning.
Actually, sir, there has been literature also shows what Koenagi-Harada has been presenting as optic nerve. Ranjan Rajendran has presented 3 cases of VKH as presented as optic neuritis. So what they suggest, every time we have to do fluorescein angiography so that we can pick up the VKH early, if at all we want to be. So these 3 cases, they has written a study, and that's the 3 cases are presented as optic neuritis, and later on normally developed optic uveitis. The possibility of actually, as Sundar said, that it also cannot be ruled out. So patient on steroids would have had latent TB would have been activated and it has caused TB uveitis, and that's what we don't want to stop that. So we have continuing steroids as well as the ATT, so that even if it is tuberculosis uveitis, optic neuritis with tuberculosis uveitis is also possible. VKH is also possible. As said, we will also consider sarcoidosis and we'll continue routing. So we don't have perfect diagnosis, but still we'll have all these 3 DD: sarcoidosis with tuberculosis uveitis and VKH also. So there are studies are there. They are present. Many cases have been presented. VKH presenting as optic neuritis. Thank you, sir. Thank you. Any other, sir? Sir, means, sir.
No, I just want, is Ashwin there?
Yes,
Yes, Ashwin there.
You did a very good job, Ashwin. You discussed very well.
Thank you, sir.
Congratulations, you did very well.
Thank you, sir.
And also, it was a very thoroughly interesting discussion. And,
Yes, sir.
yes, it was a pleasure to listen to Sundar, Priya, Chitrambalam, all the firebrand neurologists. Very happy. Arun, of course, your contribution as usual. Thank you very much for presenting a interesting case. And Justin, thank you for your contribution also.
Thank you so much, sir.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Ashwin, kindly after some time do as Priya said, OCT.
Yes, ma'am.
Retinal fiber layer thickness is thinning now, it goes for optic nerve. Second, as Sir said, Sriram sir told, always look for some sarcoid or other granuloma tests also. Sometimes it come up. So 3 possibilities. One is pure demyelinating, primary demyelinating with some infection causing uveitis. That is one. Or sarcoid or another vasculating causing both uveitis and optic neuritis. Or as you said, primary uveitis presenting as optic neuritis. I'll go for the first primary because 100% visual improvement with steroids without any other treatment. And first 4 episodes on OCTO, so nobody has told about it is all cannot miss no. So I will go more with crayon with infection causing uveitis. But sarcoid has the second. Third, probably I will accept as uveitis if second recurrent uveitis comes without any not on steroid, no infection, and your OCT is 100% normal in between. Okay?
Yes.
Go on to the next case.
Sundar, 1 minute. There are some questions in the chat box. Please find out. Chat box, there are
I do
questions.
not know, sir. How to see? I do not know, sir.
Ashwin, you can see in the chat box and answer. Okay, I can read out. Okay, first 4 episodes of steroid therapy flares latent TB presenting as uveitis is one question.
Possible.
Yeah. The second is any use of vitreal biopsy, or else, as Chitrambalam suggested, or else PET CT and biopsy of any other lesion.
PET CT you have to do, sir.
PET CT.
Chitrambalam also said biopsy of the optic nerve.
That's over, sir, but PET CT you can do.
Typical of Chitrambalam's aggressiveness.
Is there any ophthalmologist who is there to do optic nerve biopsy? They have presented a case from Austria, Vienna, where they have done optic nerve biopsy for all the 10 cases they presented. Probably India they are not doing, sir. That will clinch the diagnosis.
Yes, sir. Sir.
அதான் சுந்தர் அது சேஃபா எடுக்கிறதுக்கு ஆள் வேணும்.
அது கஷ்டம் நம்ம ஊர்ல.
So just want to add one point for postgraduates. When uveitis along with optic neuritis comes, we will have to consider multiple sclerosis and MOG. These two, especially multiple sclerosis.
Yes, that was
it has already been mentioned by Dr. Ashwin. And MOG also can present with orbital inflammation. Features of orbital inflammation can be there with MOGAD.
Yes, ma'am.
Yes, ma'am. Uveitis and upper with MS. I mentioned that also. There is one interesting last suggestion, Sakti, to everyone. All possibilities can be considered, but the treating physician is the most equipped to make the final diagnosis. Arun Raj, so it comes to you.
Yes.
Okay, thank you, Arun, and thank you, Sundar, and all the other discussants. Okay, Sundar, you can continue.
Go to the next case, Ashwin.
Yes, sir.
Ilakya.
Yes, like you are on the screen.
Sir,
Yes, like yeah. Are you ready? Ready? Yes.
yes, sir.
Okay.
Good morning, sir. Today I'm going to present a case of paraplegia. A 36-year-old male who had no previous comorbidities, studied up to 10th standard, who is a lorry driver by occupation and right-handed individual, presented with chief complaints of weakness of both lower limbs since 2 years, numbness of lower limbs since 1 year, 2 months. Coming to the history of presenting illness, he was apparently normal till October 2022. The last one. Jacob, please.
Proceed, Ma. Proceed.
He was he was apparently normal till October 2022. Then he developed acute retention of urine, but he was able to perceive the sense of bladder filling, no history of urgency, urge incontinence, hesitancy, and incomplete evacuation of bladder, no history of recurrent urinary tract infections. For this above,
Another gadget is on in your side. It is echoing. So kindly off any other gadget is on.
is around off around leave meeting. Sir.
Yes. Continue.
Yes, sir. No history of recurrent urinary tract infections. For this above complaint, he went to private hospital and was treated. He was catheterized. At the time, he was able to appreciate the catheter sensation. After 3 days, catheter was removed and he was completely recovered. During these 3 days, he had no bowel disturbances and no motor or sensory disturbances. After discharge from the hospital, he had normal bladder habits. Then 3 months later, he had one day while driving lorry, he noticed to have difficulty in using his right lower limb while applying brake. He had difficulty to press the driving pedals. Subsequently, he had difficulty in gripping the slippers on the right side. 2 weeks later, he had difficulty in right lower limb for climbing onto the driver's seat. Then 1 month later, he had difficulty in using left lower limb in the form of gripping the slippers. Subsequently, he had difficulty in increasing the pace of walking. And then he had climbing upstairs and downstairs, getting up from squatting position. For that, he used to support side rails to get up from squatting while using washroom. There is no history of buckling of knees. And he had aware history of slippage of slippers present. No spontaneous incurving or outcurving of foot. The weakness was more on the right compared with left side. However, he was able to walk without support and able to do his activities of daily living, but he was not able to grip his slippers, so he avoided to using slippers. There is no history of upper limb weakness, truncal weakness, or neck muscle weakness. He had stiffness of both lower limb, right more than left side. There is no history of thinning or twitching of limbs. No history of cramps, muscle pain, difficulty in releasing hand grip. There is no history of exercise intolerance or diurnal fluctuations. He was able to perceive smell sensation. There is no visual disturbances, no drooping of eyelids or double vision, no chewing difficulties, and sensory disturbance over face. He was able to close eyes tightly, able to drink water without spillage, able to hear, and no swallowing or speech disturbances, able to turn head from side to side, able to mix food in the mouth. And 4 months later, patient tells that whenever he takes a long drive, he developed a lower back pain, which is short, dragging type. And the pain was radiating along the buttock, back of thigh, till foot of both sides. Pain used to present intermittently and which is not increased while coughing or sneezing. Sometimes patient also used to get increased pain in legs on walking. Pain used to be more on initial few steps and he used to bend forward while walking, which used to help relieve the pain. Then 3 months later, patient developed numbness both lower limb below hip. He also had reduced pain sensation below umbilicus. He also had reduced perception of hot and cold water while bathing. He noticed reduced sensation over the perianal region while toileting. Nose of swaying in darkness, nose of uncertainness while washing face, or electric shock like pain while bending neck, or band-like sensation over trunk. Nose of hot mood sensation or burning sensation. No swaying while walking, a troublesome on reaching for object, no undue separation of syllables, or no smearing of food. There is no history of memory disturbances, seizures, sleep disturbances, or behavioral disturbances. No history of excessive sweating or palpitation, no history of giddiness, no history of loss of early morning erection. And there is no history of headache, fever, chronic cough, joint pain, rashes, oral ulcer, and no history of cold and heat intolerance, a loss of weight or appetite, no history of bony pain, drug intake, skin lesions or trauma, and there is no recent history of vaccination. Coming to the past history, no history of tuberculosis, diabetes, systemic hypertension, CAD, and epilepsy. Personal history consumes mixed diet, sleep and appetite normal, no contact history of tuberculosis. Family history, no similar complaints in the family members. Coming to the timeline of history, on February 2022, he had acute retention of urine. For that, he went to private hospital. After 3 days, he was completely recovered. In May 2022, he had right distal lowerly weakness. 2 weeks later, he had right proximal lowerly weakness. Then June 2022, he had left lowerly weakness, distal followed by proximal. In September 2022, he had radicular pain over both lower limb. For that, he take consultation from ortho department. There he was treated like L5S1 radiculopathy. Again, December 2023, he had numbness and reduced pain and temperature sensation both lower limb. Weakness was gradually progressed. Distal weakness more than proximal weakness and right more than left side. And January 2024, he had consulted in our department. Summary.
Go on.
Sir, I'm audible.
Continue.
Yes, sir. 36-year-old male patient, a lorry driver by occupation, presented with chronic neurological illness in the form of insidious onset, gradually progressive, asymmetrical, right more than left, the weakness of bilateral lower limb, distal more than proximal, associated with stiffness of both lower limb, with sensory symptoms in the form of reduced pain, temperature sensation below umbilicus, numbness below hip, which is preceded by an episode of acute retention of urine, which was completely recovered. The no history of higher mental function, cranial nerve, or cerebellar involvement.
Where is the lesion?
So structures involved the motor bilateral corticospinal tract above L1 because he had hip flexion weakness, and bilateral sensory disturbance in the form of reduced pain, temperature sensation below D10, later spinothalamic tract. And the spinal cord and the vertebral level is probably D7. He had root pain and asymmetrical weakness, definitive sensory level, and predominant human signs because he had stiffness of bilateral lower limb, right more than left. So most probably compressive extramedullary intradural lesion.
Ilakya, just a clarification. Is it a single episode? Is it a single episode which is progressing,
sir,
or is it multiple episodic? Sorry?
Sir,
am I audible?
Sir,
sorry, am I audible, Ilakya?
Sir, 1 minute. Not educate. Sir, 1 minute, sir. Bluetooth சார் ப்ளூடூத்ல இருந்து எடுக்கணும் சார். கேட்க மாட்டேன், ஹெட்செட் கேட்க மாட்டேங்க சார். சார் ப்ளூடூத்ல இருந்து கனெக்ட் ஆகும். அதை எங்க சார்? சார்
Hello.
Sir?
Now you are able to hear?
Sir, yes.
Yes. VN sir, you can proceed.
Sir?
No, I just wanted to know from the history, is it a single episode which is progressing, or are there few episodes adding on neurologic deficits?
Sir, initially he had acute urinary retention.
Yeah, that I know. Yes.
Paralytic bladder, sir. which was completely recovered after 3 days, and followed by only he developed a weakness. Every complaint it is preceded by this retention of urine only, sir.
Ilakya, 1 minute. From May 22 to September 22, was it a single episode which is continuing, or each time he had some symptom recovered and then again another symptom? Was it like that? See, this is from May 22 to September 22.
It's not audible.
Sorry, not audible.
Sir. Yes, sir, I'm not audible.
Sir, we can hear you, sir. We can hear you.
Actually, it was a single episode only, sir. It was a single episode. First episode, the acute retention of urine, one episode, and another thing, all these things are single progressive episodes, sir. It's
so in other words, two episodes.
Yes, definitely two. Retention of urine, something.
One episode recovered, and then thereafter from May 2022 till now it's progressing.
Till now it's a single episode, yes.
Okay, thank you.
Yes, sir, I'm audible.
Yes, okay. We summarize. Yes, we have summarized.
36-year-old male patient, a lorry driver by occupation, presented with chronic neurological illness in the form of serious onset, gradually progressive, asymmetrical, right more than left, weakness of bilateral lower limb, distal more than proximal weakness, associated with stiffness of both lower limb, with sensory symptoms in the form of reduced pain, temperature sensation below umbilicus, and numbness below hip, which is preceded by an episode of acute retention of urine, which is completely recovered, with no history suggestive of higher mental, cranial, or cerebellar involvement. Coming to the structures involvement, here definitely motor level and sensory level. So most probably spinal cord, and the motor tracts involved bilateral corticospinal tract above L1 because he had hip flexion weakness also, and sensory bilateral lateral spinothalamic tract below D10. And he had radicular pain and human signs predominantly, and asymmetricity was there. So most probably compressive extramedullary intradural lesion.
Why do you take vertebral level D7?
Because the higher level spinothalamic tract D10, so 3 thickness higher level, so D7.
That you consider segment level. Vertebral level now you have
D8 is the segment is D8 and vertebral level is D7.
Do you have any vertebral pain? Any pain?
No vertebral pain.
Deformity? Vertebral?
No vertebral pain and no deformities.
Why is it not an intramedullary lesion, Ilakya?
Because he had predominantly human signs, sir. He had stiffness weakness, and
why is it not intramedullary?
It's a perianal sensation also lost, sir. He had reduced sensation while washing toilet in the perianal region, and predominantly human signs are there. There is no element signs, sir. And he had particular pain is there, sir.
Pyramidal, can't it happen in intramedullary lesion?
Sir, in intramedullary lesion, mostly patient presented with element type of weakness, and perianal sensation will be starting intramedullary lesion. Sir, in this case, he had a perianal sensation was lost.
But how do you explain the bladder involvement and recovery then?
Sir, bladder was explained by he had one single episode motor paralytic bladder, sir. That could be a spinal transient ischemic vascular event. The spinal artery of the branch of internal iliac artery supplying to the conus, that is artery of Desperate quadrant, which is supplying the conus, transiently abrupt circulation. That's due to he had on episode of motor paralytic bladder.
You don't think that's an intramedullary involvement?
Followed by he had the features most probably denotes extramedullary, sir.
Sakti, you want to say anything?
No, sir. I think the everything, the neurological problem started with the bladder issues. So naturally, one will consider intramedullary pathology starts. The complaints of saddle anesthesia, Then should we consider both intramedullary and extramedullary? Then like something like cord and cauda equina.
No, Ilakya, do you follow the discussion?
Sir,
Did you listen to what Shaktivelayadam was saying?
yes, sir.
Nama, he suggested that it may be cord and cauda.
It could be one possible, sir, because he started with the bladder symptoms. That could be one possible, but following by he had stiffness, weakness, and perianal sensation was lost, sir. In intramedullary lesion, the perianal
Yeah,
span.
that's right. That's okay. That's okay. That's why he's suggesting cauda.
Yes, sir. Cauda could be one possible, sir. But he had stiffness of bilateral lower limb was there.
So, how many levels, ma? Ilakya, so how many levels?
It could be sir, prior episode maybe due to a transient vascular event. The internal iliac branch of internal iliac artery, that is artery of Desperate-Gottran, which is supplied to the conus. Just transiently, the circulation will be abruptly cut down, so leads to one episode of motor paralytic bladder that will be recovered, completely recovered. Followed by he had this weakness and sensory disturbances at all.
Sundar, you take over, Sundar.
Okay, Ilakya,
Yes, sir.
you are confident that there are 2 episodes. It is not 1 episode, correct?
So that episode followed by weakness, sir. Yes, sir.
The first was bladder.
Yes,
2
sir.
months he was absolutely normal. Then
3
he had another episode,
Yes, sir.
correct?
Episode of weakness.
So, bladder, where do you want to put the lesion? You know, you are trying to tell motor paralytic. Ne? When
Yes,
motor
sir.
paralytic, where is the lesion?
S2 to S4 lesion.
Motor paralytic in the S2 conus lesion.
Conus lesion. Conus.
Conus.
It's a conus lesion. That's why I mentioned the internal iliac artery branch.
Wait. You see, you are going to pathology.
Yes,
Site. See, always if you go by site, then what is the lesion? You won't make mistakes. Point
Yes,
is, you are again going for pathology, iliac artery. Nobody knows. I am telling it's demyelination. You are going for vascular. So leave the pathology. First point, for a transient acute retention of urine, you are telling motor paralytic bladder.
Yes, sir.
Okay, using that word, is it correct? And you think it over. But where do you want to put the lesion for that bladder? You are telling S2 S4.
Yes, sir. Yes, sir.
Conus.
Yes.
Or you want to change, you want to put that on, you have to think. Second, on the conus level, what pathology do you want to put? Why you are thinking vascular? What is the age?
36 years ish. It's 36.
Okay, why you are again telling it is a transient ischemic attack? Can it be any intramedullary demyelination? It can come, anything like that? Because if you are able to, that first episode is the clue. See, if it is only second episode, it can be an extramedullary, because it's an asymmetrical onset. It is not a symmetrical onset, it's an asymmetrical onset, and it picks one tract. Finally, first cortex spinal, then spinal thalamic. Okay, we can think of an compressive pathology. But the first episode is the clue. First episode, there is a bladder symptoms and it improved. So, we have to put 2 things. Where is the lesion and what is the lesion for that? So, he improved completely, no?
Yes.
So, only what think of TA, correct?
Yes, sir.
Could it be any demyelination?
But in the previous episode, he had no bowel and bladder worsening symptoms.
Bladder was the
Ilakya,
Yes, sir.
you are discussing only the first episode now.
Yes.
That is what Sundar is asking. Forget about what happened subsequently. We can try to link the 2 later. His questioning is only about the first episode, where it was a bladder involvement. What he is asking is, could this be a demyelinating lesion? Forget about what happened subsequently.
Okay, sir.
You answer that question alone.
Could be possible for demyelinating pathology.
Okay, because you have to put a vascular transient event or demyelination or something which is improving on
Yes,
its own because he never had bladder later.
yes,
Then if you are fixing that pathology, then we'll come to this present, where is the lesion, what is the lesion? Where is the lesion you want to put as D7 segment,
T8 is a segment 8.
T8. Okay, the T8 segment, what pathology do you want to put for the second episode?
From this second episode,
Pathology.
extramedullary
You leave alone this, the level now.
Yes,
What pathology you want to put from the history?
yes, sir. History-wise, some extramedullary intradural lesion.
You said compressive.
Yes, sir. Compress.
So you want to put two pathology, no? So first episode you want to put a vascular bar demyelination. Second episode you want to put a structural lesion. That's what you want to put on, I'm asking.
Yes,
Be bold, ma.
yes, sir.
Ilakya? Okay.
Okay, you carry on. Next,
You carry on. No.
Sir, I would like to give some of the differential diagnosis, sir.
Carry on.
Sir, it is mostly the compressive extramedullary intradural lesion at the level of something about T8 level, sir. So extramedullary intradural lesion, the probable differential diagnosis in 36-year middle age. So any benign tumors like neurofibromas or meningiomas, but the neurofibromas, there is no other, or for neurofibromas, he had no other skin lesions and no other manifestations of neurofibromas. And meningioma also, he had no headache and there is no increased intracranial pressure features. And second differential diagnosis, arachnoiditis, spinal arachnoiditis could be one possible because he had previously he had one episode of bladder symptoms. Then only he developed the motor and sensory disturbances. The third differential diagnosis could be any vascular etiologist, any vascular malformation, spinal vascular malformation. Because in spinal vascular malformations, vascular etiology also, he had previous one episode which was completely recovered. Then only 2-3 months later only he had motor and sensory disturbances.
And demyelinations.
Shakti, again you said something, but you are not audible.
Sir,
What is it that you want to say? Solunga.
Still, we can consider a demyelinating disorders, sir, involving the cauda equina and spinal cord. Recently we are seeing many cases of Mark syndrome involving spinal cord and cauda equina. And without any specific treatment, the initial urinary retention improved. That unlikely to happen with vascular issues.
Ilakya, your response to that suggestion?
So that the demyelinating lesion also could be one possible etiology, sir.
And the progressive illness ka?
Yes, sir, because the bladder symptom recovered, then only he developed other symptoms 3 months later only. So that could be one possible, sir. Demyelinating etiology also could be one possible. Cauda equina with other lesions.
Actually, it looks like recurrent episodes, sir. It is not an insidious and slowly progressive illness.
It's
a sequential involvement.
February 22 அப்புறம் 24 வரைக்கும் it's progression. One episode progressing தான் அருண் ராஜ் சொன்னாரு.
Yes, but it is better to put like recurrent episodes to discrete episodes.
2 discrete episode, but the second episode is a progressive episode. For
Yes,
2
sir.
years, it's been progressing.
Yes, sir. Then you'll be having additional burden.
What is the
Additional.
weakness level from for the 2 years? Weakness, the weakness worsen progress from what to what?
So initially he had a right distal lower limb weakness only. Then one by one he developed. Then one
Not the progression.
Yes,
The
sir.
power it does it progressed from
the
5 by
power
5 to 0 from the Marian.
Yes, sir. Initially, he was able to put the slippers, sir, but difficulty in gripping the slippers only. But later on, he was not able to grip the slippers at all. So he avoided to using slippers himself. And initially, he was able to get up from squatting without with mild difficulty only. But later on, he used to support the side rails to get up from squatting also, sir. So the weakness also progressive.
Now he's walking up with support, without support.
Sir, without support, he was walking, sir, but not in the other pace. He was able to walk only slower pace, sir.
But he's able to walk without support now, even now.
To walk, but had difficulty, sir. But had difficulty, mild difficulty.
Okay, radicular pain over both lower limbs, no? Radicular pain over lower limbs.
He had radicular pain in both lower limbs, sir.
That is probably LPS1, huh? Bilateral.
Yes, sir, because the pain spreads to back of buttock, back of thigh, up to foot of the both lower limbs. S1, S2 segments, sir.
So can it occur in demyelination?
Radicular pain, it's not much possible, sir.
Unless it is Shakti was telling, no?
Yes, sir.
Can it occur like that? See, 2 points. The radicular pain, what is the pathology that you want to put on? Second, for the 2 years progression.
Yes.
Demyelination can be 2 years progression.
Demyelination, sir, without any relapsing, he was progressed, sir. So, in demyelination, in between 2 years, he had at least one episode of relapse will be occurred.
Primary progress, it is a progressive demyelination can't be there, but it is such a slow demyelination.
Progressive also comes, but it.
Like, can the progression be this much slow? Can the progression be this much slow? 2 years like is still walking.
Yes, sir. Still walking.
Okay, carry on. Go to the examination.
General examination was conscious oriented, vitals pulse rate 80 per minute, regular, normal volume. All peripheral pulses felt equally. Blood pressure was 120/80 mmHg and respiratory rate 13 per minute. Saturation was 99% in room air. Temperature was 98.4 degree Fahrenheit. Peripheral pulses equally felt. And general physical examination, there is no pallor, ictus, pill edema, and lymphadenopathy. No kyphoscoliosis or other skeletal deformities. Skin, hair, nail was normal. His height was 158 centimeter and neck height 12.7 centimeter. Height neck ratio was 12.4 centimeter. And coming to the higher mental function, MMSC is 29. He lost his point in recollection. And examination of cranial nerve was normal. Coming to the motor system examination, bulk was normal, and in measurement, there is no asymmetricity in between both upper limb and lower limb also. And tone, bilateral upper limb normal tone and bilateral lower limb grade 2 spasticity was present. And power, neck muscle flexion extension was normal, and upper limb power was 5 in both sides, and hand grip was 100% in both sides. And lower limb power in hip flexion 3 in right side, extension 4, and adduction 4, abduction was 3. In left side, flexion extension, adduction, abduction was 4. And in knee, flexion extension 3 in right side, 4 in left side. And ankle, dorsiflexion 3 minus by 5 in right side, plantar flexion 3 by 5. In left side, dorsiflexion 3 by 5 and plantar flexion 4 by 5. Inversion, eversion weak on both sides. Coming to the reflexes, superficial reflex, corneal conjunctive was present, abdominal reflex, upper abdominal reflex was present, and lower was absent. And other superficial reflex was absent, plantar reflex, bilateral extensor. And deep tendon reflexes Georgia absent, upper limb reflexes present, and knee jerk 3+, ankle jerk 2+. There is no patellar or ankle clonus. And B was positive. He had spastic gait. Sensory system examination, spinal thalamic pain and temperature reduced from T10, dermatome in both sides. Vibration, spinal vibration impact below T10. Position sense impact in both lower limb. So this is late. Pain and temperature reduced below T10. Roberts was positive. Cerebellum function, there is no titubation, no truncal stance or gait ataxia. Speech was normal. No hypertonia. Tandem work could not be performed. Extrapyramidal system, no bradykinesia. There is no involuntary movement. Autonomic nervous system, no postural hypotension. Sweating normally in both sides. There is no signs of miniature irritation. Examination of spinal cranium. Spine, there is no bony deformities, gibbous tenderness. There is no bruit. And cranium, no bony abnormalities. Examination of other system, cardiovascular system, exonestrial, no murmur, respiratory system, chest symmetrical, and normal vesicular rhythm heard in both sides. There is no abnormal or added sound. Abdomen is soft, there is no organomegaly. Summary, middle-aged male, MMSC was 29. Motor system examination shows bilateral lower limb spasticity with bilateral lower limb weakness, distal more than proximal with BVO positive with bilateral plantar extensor. Sensory level shows cerebrospinal thalamic tract T10. Spinal vibration also impact below T10. Cranial nerve cerebellum was normal.
Ilakya, can you give the description of the pain which he had? You said the pain was in both lower limbs.
That radicular pain, sir.
Let's come to radicular. That is within inverted commas. You just described the pain. Pain was in both lower limbs.
Yes, sir.
What was the nature of the pain? Or in other words, why do you say it is radicular?
So patient tells he had pain whenever he takes long drive, which is
Sorry?
short dragging type of pain, short dragging type, which is radiate along the buttock and back of thigh till foot of both sides. And pain used to present intermittently. Whenever he takes long drive only, he had this type of pain. So fluctuating pain only, not persistently he had. And also the pain was not increased on while coughing or sneezing. And sometimes patient also used to get increased pain in legs from walking also. Pain used to be more on initial few steps and used to bend forward while walking, which used to help relieve the pain. So he had claudication type of pain also he had, and radicular type of pain also he had.
What is the radicular type in the description which you are given?
The pain was short dragging and which follows the route, respective route. So in buttock, back of thigh till foot of both sides. So S1 is to route. The pain follows the radicular distribution and which is short in nature.
And it is in both lower limbs.
Yes, sir, both lower limbs, sir. Till foot of both side involved.
Can cord involvement produce pain?
Yes, sir. Track pain also be one.
Sorry?
The cord involvement, root involvement, in addition to cord, root involvement can present this type of pain, sir.
No, I'm not asking about root. Yeah, you said about root. I'm asking you whether cord involvement alone can present with pain.
Yes, sir. Track pain, that is track pain. Involvement of spinal column, posterior track involvement, track pain, cubical in each of that. That will be presenting intramedullary lesions, the track pain.
No. So that a track pain also can happen with the involvement of both lower limbs.
Sir, in spinal cord involvement, track pain also present, sir.
Yeah. So your differentiating point between a track pain and a radicular pain in this patient is?
Sir, in the track pain is the pain which is not in the localizing value, which is distant from the site of lesion, sir. It's not exactly on the site.
Yeah, your site was somewhere in the about T7 or T8, and the pain is in the lower limb. So it is away.
So the pain was back region only. that is radiating to the buttock back of side till foot, sir. But the pain is in the back region. If it is a track pain, which is not in this back pain, which is present elsewhere distant from the site of lesion.
Okay, continue.
The sir is asking whether it's limits pain or not.
Sir, no electric shock like sensation, sir.
Correct, ma. The track pain also is away from the site of lesion, isn't it?
Yes, sir.
That is what you are saying. It's away. So that is not the point to differentiate a track pain and a radicular. I'm not saying it's not a radicular pain, but the pain being in the lower limbs, away from the site of lesion.
The track pain, which is not in short characters, a short character, which is ill-defined.
Okay, that point is agreed. Yeah, that's what.
Yes.
But okay, the distal referral is not necessarily a radicular. It could be a track pain also.
The second line, the patient used to get increased pain used to few steps. That claudicated pain, where do you want to put relation?
He also had neurogenic claudication, sir, because the pain used relieved by bending forward, sir.
Why it's happening?
Sir, some neurogenic claudication, sir.
What pathology? Why this patient has neurogenic claudication?
Sir, in lumbar canal stenosis also, patient had neurogenic claudication, sir.
Okay, but your level is D7, no?
So you're again coming to what Shakti said, Cauda equina.
Yes, sir. Yes, sir.
But your level is spinal cord D7, no?
Yes, sir.
So how do you link the two? How do you link the two?
Only thing which could be linked is the compression somewhere, the localization somewhere due to compression of due to compression of some arterioveno.
Yes, sir.
See
Venous edema or venous congestion will produce like this false localizing pain, sir.
Yeah, wait. Sundar is trying to say something. Sundar, solunga.
No, sir. See, this patient has two things which is not exactly fitting. One, why did the bladder happen and improved on its own? Second, this is a 2-year illness. And 2-year illness, you're still walking with support. And probably இதெல்லாமே ஒரு step by step இருந்ததா இல்ல chronically progress on, we are not sure. So I feel it could be, the lesion could be in the as she said intradural, somewhere like that, some vessels and causing ischemia, causing multiple symptoms one by one on but only point is, if it is an antecondylar ischemia, the improvement won't be there. So but the clue is in this neurogenic claudication for what is the lesion. This the problem should be there, which is causing all these problems, which is the patient is present. That's what I'm thinking.
There is no wasting, no twitching, no fasciculations.
Yes, sir. No wasting, no twitching, no fasciculation.
Okay, fine.
Okay, carry on from where we left.
So summary.
B was positive. B
was positive, Sundar.
That's a localizing.
Just thinking about B was positive.
Yes, sir. B was positive.
Continue with your discussion.
Yes, sir. A summary, 36-year-old male, higher mental function MMSE was 29, and motor system examination shows spasticity in both lower limb weakness, distal followed by distal more than proximal and right more than left, with B was positive with the bilateral plantar extensor. And sensory examination shows lateral spinal thalamic tract at D10 and the spinal vibration impact below T10, so posterior column also D10. Cranial nerve and cerebellum examination was within normal limit. So the motor level B was positive, so D10, and sensory level is D10, and reflex also, upper abdominal reflex was present and lower abdominal reflex was absent, so D10. Vertebral level is D7.
Continue.
Proceed. Proceed.
Sir, investigation.
Okay,
Yes,
is this
yes.
a transverse myelopathy?
Sir, but the patient had progressive weakness, sir. Progressive weakness of 2 years, sir.
Myelopathy, that's what I is telling, not myelitis.
Myelopathy.
The question was, is this a transverse myelopathy?
Sir, transverse myelopathy could be one. Sorry, the bladder symptoms was completely recovered. Then only he had progressive weakness, sir.
Yeah. Correct.
Yes, sir.
But your level is all at a single
Yes, sir.
level.
The level is all one, sir. Yes, sir.
At that level, everything is involved except the bladder and bowel fibers.
Bladder, yes, sir. Bladder and radicular pain also he had. That is in the lower back region and extending up to foot.
So, in other words, it's a myeloradiculopathy.
It's a myeloradiculopathy because of radicular involvement in root pain. But the reflexes was brisk. In radicular involvement, the reflexes was
இப்படியும் சொல்லி அப்படியும் சொல்லக்கூடாது. You are saying both.
No, sir.
Something.
The cord involvement with the radicular pain, sir.
So that's what I said, myeloradiculopathy.
Myeloradiculopathy.
That's what you are also saying. I'm just repeating what you said. And I asked whether it was a transverse myelopathy. These are questions which you will be, which you should expect in the exam. Yeah. I mean, Sundar is a more recent examiner, so he will let you know.
Sir, we'll carry on, sir. We'll go for investigation appointment discuss.
Okay.
So investigation, routine blood investigations are within normal limit. Imaging was taken. This is MRI spine sagittal T2 section shows multiple flow voids from the lower cervical and extended up to dorsal level, and also the cord edema also seen in dorsal regions.
So it's an MRI diagnosis now. MRI diagnosis.
But he no, sir, but he had clinically also one preceding episode of retention of urine, which is completely recovered. Then only he had that progressive weakness. He had multiple time consultation also taken, but he didn't diagnose.
Continue.
And
the axial section shows D10 level in right posterolateral region. Multiple flow voids will be seen and cord also edematous.
Very nice.
Then the patient was further evaluated and posted for DSA, sir. So under aseptic precaution from right femoral artery, we should inject the guide wires, sir. And then contrast was injected to see flow voids. So this is D12 radicular arteries. From this level, we have to screen for any flow voids. So this is the anterior spinal artery. So in the distal segment of anterior spinal artery, we should see multiple flow tortuous vessels with flow voids. So this is the AV malformation. The feeder vessels for anterior spinal artery. The vascular malformation, which is more anterior to the cord, ventral to the cord. So the ventral to the cord, the malformation was surgically inaccessible. So we should plan for glue injection and occlude the distal feeder vessels. So from the same sitting, we used microcatheter to inject a glue to occlude the distal vessels. So this is a micro catheter. We inject the glue to occlude the distal feeding vessels.
Very good. Done at KAPV, yeah?
Yes, yes.
In KAPV, sir.
Very good, very good.
And
Proceed.
sir, this is post embolization. Check DSA was taken, sir.
This was done by the radiologist,
Oh,
isn't it?
this is check DSA. There is no feeding vessels. The flow voids was reduced, sir.
Okay.
Done by neurosurgeon.
Oh, done by neurosurgeon.
Yes, interventional neurosurgeon. Dr. Harigarasudan.
So there is no flow voids in the ASA segment. The distal feeder vessels were completely occluded by the use of glues.
Good.
There is no feeding vessels. This is the check DSA.
Very good, very good.
So this is the spinal AV malformation. This is from the anterior spinal artery, most distal portion, and this is the extramedullary. So this is the type 4 a perimedullary spinal AV malformation. If it is a AV malformation anterior to the posterior to the corner, we should plan for laminectomy, other open surgeries, which is more anterior, so which is surgically challenging. So the spinal AV fistula type 4B was found to be at the level of D12. And we should inject after diagnosis of spinal AV fistula, which is surgically inaccessible as it was anterior to the dorsal cord. So the anterior spinal artery was catheterized via the D12 radicular artery using marathon catheter with great difficulty. The distal segment of ASA, which was feeding the fistula, was reached. The embolizing agent N-butyl cyanacrylate was freshly prepared and then injected, thereby achieving the complete embolization. The check DSA revealed no flow through the AVF. So after achieving the appropriate results, the guide wire and sheet recovered and femoral compression given, and the patient shifted to ICU.
How is the patient now?
Sir, at present, he had only the pain was minimally improving, sir, but the status was
Pain was minimally, sorry?
Minimally reduced. Pain only reduced. That the radicular type of pain only reduced, but the weakness was persisting. There is no improvement in motor weakness, sir.
No improvement.
No improvement, sir. Because which is the embolization will not give the good prognosis. Only the procedures, either laminectomy or other open procedure to completely remove the AV malformation only will give good prognosis. Which is surgically inaccessible procedure only, sir.
So the purpose of gluing?
Sir, if we not remove na, the feeding vessels will be keep on progressed, sir, and the patient kept on deteriorating. At present, he had weakness of 3/5 only. If we not remove na, he had progressive weakness and some.
Okay, you arrested further progression.
Yes, sir.
Possibly you arrested further bleeding also.
Yes, sir.
Okay. How long has it been since this procedure was done?
Sir, this procedure was done by last March, sir.
Oh, it's 1 year.
Yes, sir, last March was done, sir. The patient was under follow-up, sir.
And in the last 1 year, he has not improved?
No, sir, no improvement, sir.
Okay. Sundar,
yes, sir. It's, can you tell me why it's not improved?
Sir,
The main differentiation between vascular and compression is that in compression, if you remove the problem is due to compression, if you remove that, it will improve. But in vascular, due to ischemia, there will be damage to the neurons. So probably you can expect less improvement. So the clue for the bladder is then probably ischemia to that area, from the AVM.
Yes, that's what's retrospective diagnosis.
Yes, sir. Very good, sir.
Retrospective.
And what do you feel, sir? This is due to this D10 level, due to AVM compressing from external this problem, or venous congestion, or inside there is infarct. That is the reason.
Only venous congestion we have to consider. I don't think it's in either
Yes, sir. Because if it was only purely due to compression on, we have to remove that.
Remove that. Yes, yes, sir. There's no evidence of any compression other than apart from this. So that's what actually the first diagnosis. First, when she is almost biased, that's what she is telling, feeding artery. That's what the first episode. So whenever if we don't read the MRI,
she gave the clue away. Actually, she gave a clue away, sir. I think why she is telling that.
That's what based on the MRI report was telling the artery in the first episode, right? That's what you should not get biased by the MRI report. That's what. Otherwise, we have done treatment for this, but patient doesn't have improvement, as you said, probably due to the vascular insult. And also, we have to do earlier, whenever as the AVM is being identified, we have to do as early as possible. Delay will also might not cause so much improvement, as the neurosurgeon said like this only. So that is also one thing we have to think of. But patient didn't have any improvement, but otherwise, at least the patient won't aggravate, and the illness won't aggravate. That's what.
The 1 year no worsening, sir. The 1 year no worsening.
No worsening.
That's probably that is the victory of the operations.
Yes, that's sir.
Sundar,
sir.
Venous congestion versus arterial involvement. Which do you think is likely?
In the patient, sir? இது கீழே தான் இருக்குது, அதனால probably arterial.
Yeah, venous congestion கொஞ்சம் improvement எதிர்பார்த்திருப்போம்.
ஆமா, இருக்கலாம். இல்ல இதுல என்னன்னா சார் which tract is getting affected?
எல்லா tract affect ஆயிருக்கேமா?
Anterior is not affected.
அதான் tract சொல்றேன். I am talking of the tracts.
Because இப்போ anterior console சப்ளை பண்ணக்கூடிய ASAவோ இல்ல radicular artery இருந்ததுன்னா இன்னும் வேஸ்டிங் வீக்னஸ் ஏதாவது கொஞ்சம் வந்து
அதான் கேட்டோம். ஒண்ணும் இல்ல.
இது வந்து more அந்த D10ல சரி, I feel it is D10ல அந்த வெளியில இருக்கிற அந்த AVM போய் அதை கம்ப்ரஸ் பண்றதுனால தான் the whole problem is.
Yes.
When compress with more than I feel arterial இதுவோ.
Correct. That's what it looks like.
அப்படி arterial இருந்தனா இன்னும் மோசமா இன்னும் worsen ஆயிடும்.
So அந்த பெயின் வந்து funicular pain தான் சார், இல்ல சார்?
Funicular pain சொல்ல முடியாது சார்.
Lower limbல pain.
Pain is radicular only, clearly radicular only, because you can have a distant radicular involvement in dural fistula because of the venous congestion. That's a lesson of this case.
இல்ல அதுல வந்து டிஃப்யூஸா இருக்கும், பெயின் டிஃப்யூஸா இருக்கும்ல சார். இதுல வந்து நல்ல ஷார்ப் டிராகிங் பெயின், ஒரு ஏரியா வேற சொல்றா கரெக்ட்டா எக்ஸாக்ட்டா.
And depends on the description which the patient gives.
Sir, this is a radicular pain clearly by the description, sir.
ஆமாப்பா, agreed. அதான் description which patient gives no matters.
Yes, sir, that can happen in a dural fistula at the distant side.
Yes, of course. Congestion. Yeah, correct. Now that we have the diagnosis, yes, we can certainly say.
Sir, the reason for not improvement is it that there is any other feeder? One feeder was identified and blocked. Is there any other feeder? Sometimes it's even very experienced intervention radiologists miss one feeder. So, is it possible that
the compression is still there? சித்ரமன் சார், அந்த கம்ப்ரஷன் இன்னும் இருக்குல்ல?
இல்ல, கம்ப்ரஷன் இல்லாத வீனஸ் கன்ஜெஷன் தான் சுந்தர் இதுல மெயின் பெத்தாலஜி.
ஆனா வீனஸ் கன்ஜெஷன் அதுதான் இப்ப பாயிண்ட். இப்ப இந்த பேஷண்ட் இருக்கிற D10 லீஷன், D10 பெத்தாலஜில இருக்கிற இது வந்து அந்த D10ல இருக்கிற லெவல்னால அந்த வெளியில கம்ப்ரஷனால ப்ராப்ளமா இருந்ததுன்னா ஸ்டில் இட் இஸ் தேர், இட் won't improve. ரெண்டாவது கன்ஜெஷன்னால இருந்ததுன்னா இன்னும் anterior console எல்லாம் போயிருக்கணும்ல.
Once in the dural fistula நீங்க அக்ளூட் பண்ணீங்களா அந்த கம்ப்ரஷன் போய்டும்ல, the AV fistula will go.
So that's what I'm Sundar, அது AV malformation சொல்றாங்க. She said it's an AV malformation.
AV fistula. Yes, AV fistula.
Fistula possible, yeah.
Extradural AV fistula, yes sir.
அவங்க malformation வார்த்தை யூஸ் பண்ணாங்க. But anyway, அது depends on what the surgeon found. Whatever it is, if the feeder had been occluded, the malformation or the fistulous lesion should have shrunk. Once it has shrunk, the compression element is going to be less.
Yes, sir.
I'm not sure.
Now the venous stasis has been there for quite a long time that it has produced some irreversible damage, or there is one other feeder which is still causing the trouble. So that is possible.
So long-standing cases causing irreversible damage.
Yes, that's possible.
That's possible.
Yes, sir. Yes, sir.
And there
It was
is
too late to interfere in this case because the patient came very late. That is possible, sir.
For venous congestion, I'm just speculating or that wild thought. Anti-edema measures helpful இருக்குமா?
இல்ல சார், as long as the venous obstruction is persisting.
The compression தான் relieve பண்ணிட்டோமேப்பா.
Yes, sir. Yes.
Sir, is it more of a venous congestion or it is more of a arterial steal, sir? It is going spinal cord ischemia.
See, that is what we discussed. Venous
directly going from artery to
we
venous
are coming
side
back
without...
to the same discussion again. But whatever it is, arterial steal இருந்தா இப்போ அந்த அக்ளூட் பண்ணதுக்கு அப்புறம் it should be worse. Depends. I'm sorry. If it's only a steal, it may not become worse. Yes. Anyway, several things we don't know.
Thanks.
Yes, sir. What else can be done, sir? Is there anything else that could be done? Chitramalam, Sundar, Arun, is there anything else that could be done?
See, it's not worsened, no, sir. So probably due to venous congestion, already something damaged, it is persisting. That's all.
அவ்வளவுதான். Right.
அவ்வளவுதான்.
Yes, sir.
The 1 year I'd seen is still there is no progression. That's what's the whole victory of that surgery.
Yes.
Yes, sir. Yes.
But if the new signs appear, then we will have to repeat the dural spinal.
The ஒரு feeder
Yes,
எடுத்து
yes, the spinal DSA should be repeated if there is at least any new signs, and you should look for more feeders.
Okay, sure. If it worsens, we have to do DSA again.
Yes, sir. Sundar, you can wind up, Sundar. Thank you.
Very nice presentation, sir. From both of the cases are very good, sir. Dr. Arun and sir. Congrats to the team, sir. And the first Ashwin is very good. I congratulate both of the presenters.
Thank you, sir. Thank you, Vivian sir.
Since it was Sundar plus Vivian sir, it was a very sweet combination, and we enjoyed the Sunday. Sundar plus Vivian sir.
You Priya just taking part also. Yes, that was very interesting. At least to me, it was more interesting. Ilakya இருக்கீங்களாமா? இன்னும் கொஞ்சம் கேசஸ் டிஸ்கஸ் பண்ணணுமா நீ? Before your exam? Yes, make more presentations and discussions. Okay, you did very well, but you still should do. Yes, ma'am. Arun, thank you, Arun. Thank you very much.
Thanks, Vivian sir. Thanks, Sundar sir, Chitrambalan sir, everyone for giving the opportunity. It was a nice one. Thank you.
You provided very good cases, and we had very good people to discuss.
Okay, that's fine, sir.
Yes, sir.
Thank you.
Thank you, sir.
Thank you all. Thank you, Sundar. Thank you, Chitrambalan again. Thank you, Priya. All of you. Thank you, Justin, for all the discussions that you had. Yes, Sundar. Thank you, one.
Thank you, sir.
Thank you. Sun team, can we leave?
Thank you, sir. Thank you. Yes, sir. Thank you.
First, most important is to thank the logistics provider, the team of Sun Pharma. Yes.
Thank you, sir.
Thank you very much for keeping us going.
Yeah, thank you, sir. Thank you. Thank you,
Kapil.
Thanks a lot, sir.
Thank you all. Is there no chat box question?
இருக்கு சார் 2-3
எனவே போயிட்டாங்க அவ்வளவுதான். சரி, தேங்க்யூ
சார்.
யாண்டே